It's my pleasure to introduce Dr. Sigurd. He's been integral faculty for this course over the years, esteemed orthopedic spine surgeon, professor of orthopedic spine surgery. He'll talk on the use of neuromonitoring modalities in complex spinal deformity surgery. Thanks, Dr.
Well, thanks, Kyle, Lee, and Lionel. Thanks for creating such a terrific program again this year. I'm happy to contribute. So I'm going to talk this year about neuromonitoring, and specifically, we'll talk a bit about neuromonitoring in complex spine surgery, but we'll also talk about it in other, maybe less complex situations. My disclosures really aren't relevant, I think, to nerve monitoring. Just as an overview, I think that we get more advanced in our techniques for deformity correction, we're putting the neural elements at risk. We put them at risk from direct injury, from vascular insufficiency, and from spinal cord dysfunction and stretch. So rates of neural injury and deformity surgery, importantly, have been described very variably in the literature. So a lot of the old SRS, M&M databases would be rates of less than 2%. But when we really look at follow-up of complex surgery, we're talking about rates of over 20% of measurable postoperative motor deficits. And neuromonitoring certainly can be very useful in detecting deficits and enabling the surgeon to respond to changes. And these are really our nerve monitoring saves. I think that nerve monitoring is really well established in adult and pediatric deformity in terms of safety, but I think there are some controversies on the cervical spine when we're using nerve monitoring for peripheral nerves, spinal listhesis, and I think there's a lot of evolution in terms of some of the techniques for nerve monitoring, and we'll go through some of those controversies in some detail. I think the underlying theme here, and one of the things I like about this course is people coming from all over the country, all over the world, and there's a lot of variation in how we utilize nerve monitoring in spine surgery. And part of that is reflected by the differences of cases. So I think there's a pretty good consensus, and the SRS certainly is the one organization that actually makes a recommendation for nerve monitoring. It's sort of interesting. NAS doesn't have a clear position on this because when we call something the standard of care, it has major implications to how we do surgery. So, but the SRS has made a clear recommendation about the efficacy and validity of nerve monitoring. But and certainly in spinal cord, intradural pathology, nerve monitoring is pretty well accepted. But in lumbar degenerative, cervical myelopathy cases, I think the consensus is less clear. And this is a nice paper that Larry Lanke wrote about nerve monitoring, suggesting that there's a lot of variation, again, in the use of nerve monitoring, whether we're at the cord level, the root level. But a lot of this also has to do with the hospital, insurance status, and some social determinants of health. Overall, a significant increase in use of nerve monitoring over the past 20 years, and recognizing some of the major risk factors for changes. Well, certainly patients with a preoperative neural deficit, patients with a sharp deformity, right? So the deformity angular ratio being sharp, either in the kyphotic plane or in the coronal plane. And when we're doing significant cord shortening, that can also be a risk factor for neuromonitoring changes. And it's certainly, we recognize this is an important part of safety in deformity surgery. So I thought, Lionel, you said make it interactive. So let's be interactive. And I'm looking to our fellows here. Where's Austin? Where's Astra? Who else is? Astra didn't make it yet. Okay. Well, maybe we'll target you. So 16-year-old female. It's an interesting story. I treated her mother. I did a fourth surgery on her mother for junctional pathology. She had had an adult deformity, and we all recognize the extent of complications there. So this is a 16-year-old, and her mother didn't want her to have the same experience. 3CN curve. And I'm just going to give different scenarios. None of these happened to this patient. But if, for example, you position a patient, you're not able to get baselines. Austin, what do you think? What are your thoughts? How do you? Yeah, so you go through a bit of a checklist, right? And then if you're not able to really solve that, you probably wake the patient up. You wouldn't start surgery in a case like this. You wouldn't start an elective case without getting signals. Whereas there might be some other cases where we might still start a case, right? Well, what about in this scenario? And Steve Lewis has done a lot of work on the different types or different patterns of neural loss. So now imagine that no baseline neural deficit, but during the correction on concave side of the curve, unilateral left-sided loss, about 75%, no SSAP changes. Anybody else want to, who's got an idea? Lionel, what?
during correction, first thing to think about is cord stretch from the correction, either globally or segmentally across the apex. Other things I've encountered with this scenario is for those of us doing type 2 osteotomies, you have a small fragment of bone that's fallen, adjacent to a pedicle and is compressing the cord. I actually had a case where I had just one myotome go out, and I was chasing motors for a half hour before we realized it was just one piece of bone that knocked out the tibant. So I think on that checklist, of course, you have the anesthetic constraints, relax your correction, but also check your osteotomies, make sure there's nothing compressing the cord.
Yeah, so certainly, thinking about the unilateral concave side, doing your type 2 osteotomies, this could be a direct injury, it certainly could be a stretch. And again, Steve's done a lot of work with trying to characterize the different patterns of loss. But this is one where you probably reverse the correction, right? So you take out that concave rod and maybe look directly, but certainly you'd reverse the correction and increase the pressure. What about this scenario? The idea that, so we get our correction, and 15 minutes after we get the correction, motors start to drop. Maybe got an idea, what would you do? What would you do here? So 15 minutes, you're into your closure by now. Kind of want to move along. Maybe you've actually even left and you're in your car, letting a fellow close, Austin. So what happens now? Austin, do you call the attending back? Let's try it. Yeah, this might be one where I'd be thinking more of a vascular type problem, get the pressure up, and I'd probably remove the implants and reverse the correction, right? Even if it's 15 minutes out. But this is for Steve. And again, a lot of variation in how we might respond. But this is a really nice paper to Steve Lewis, who's one of our esteemed guests for this course. The idea of correlating the changes that we're seeing with the anatomic distribution of the spinal cord and recognizing different types of losses, different patterns of losses. And this paper is really thorough in terms of looking at when is there loss, during instrumentation, during decompression, during osteotomy closures, and what are the responses. And it's actually an observational paper, or it's actually an expert opinion, isn't it, Stephen? It was done a lot of variation in how people respond to these scenarios. Here's something that in my room, I think was up for a long time. I don't think it is right now. But this is John Ziwatz, was a neurosurgery fellow who was a terrific fellow. And he also had worked with Atul Gawande, who did the checklist manifesto. And John led this paper with Berven and a number of us creating a neuromonitoring checklist. And this is something I think is worth actually having as a protocol. And one of the things Steve has talked about is the fact that we don't have a real strict protocol. So in the OR, there's a role. What you recognize is a role for everybody. There's a role for the surgeon, role for the anesthesiologist, role for the neurophysiologist, role for the other staff in the room. And each of those roles, so for the surgery, surgeons stop the manipulation, assess the field, think about further decompression, consider reversing, or in some cases, actually consider shortening the spines further. And I'll show you an example of that. Another effort at this, and maybe more complete, was Mike Vitale and Larry Lenke, looking at the different stages, and I think, Steve, you were part of this too, the different stages of the surgery. So during the correction, during the osteotomy, and the decompression, and even going through after the surgery. And again, recognizing that there are different patterns. Sometimes it's an isolated MEP loss, might be unilateral, might be bilateral. If there's MEP and SSEP losses, that might portend a worse prognosis. But these patterns really ought to guide an informed approach. So with that in mind, moving away from the adolescent with scoliosis, how about a 17-year-old boy? This boy is from up in rural Nevada. He's a big hunter. And he's 17 years old now. Long-standing back pain, but over the last year, he's developed progressive weakness to the point where he ties his hiking boots so tightly because he's got bilateral foot drops. So he comes with this dysplastic olisthesis. And here's a case where I'm doing a sacral dome osteotomy, pull an L5 back, get L5 reduced, and we're running multi-myotomes with the MEPs. And the MEPs dropped by about 50%, 70% to the right foot. So at baseline, we were getting some. They were actually a little weak at baseline, but they actually reduced further during the reduction. So, and not to belabor this too much in the interest of time, so I did further shortening. And eventually what I ended up doing was an interesting compromise. I felt that every time I got L5 all the way reduced in this high-grade dysplastic olisthesis, the L5 signal is reduced. So I actually left him with a little bit of anterolisthesis. So I only reduced him from a grade 4 to a grade 2. You see there's still some anterolisthesis there. And I used the Bowman technique here. So I still got the correction of the lumbar sacral kyphosis, but not a complete reduction. And I think that that's an important thing to think about in some of the spondylolisthesis cases. So we looked at this as well at UCSF, and this was led by our spine anesthesiology staff. And we've been very lucky to have anesthesiology, or a specific team of anesthesiologists with Jeremy Lieberman and John Feiner in the past when this was done. And we actually looked at over 500 cases of patients with lumbar sacral deformity. So they either had an L4, L5, or an S1 PSO, or they had a dysplastic spondylolisthesis. And we found that post-operatively, about 5% of these patients had some weakness to their anterior tib or their EHL. And 2% of them, half of those were significant weakness, meaning less than 3 out of 5 in strength. What we found here was important. So this is looking well below the conus. So this is no longer at the spinal cord, but this is at the nerve root level. And what we found is looking at multiple myotomes was really quite sensitive. And you all recognize the threshold of 50%. Well, part of this was validated by the study where 50% was very, very sensitive as well as specific for somebody having a postoperative deficit. And that this really was, I think, a landmark paper for the importance of looking at multiple myotomes to improve sensitivity to peripheral nerves. And this has also been demonstrated. This is a multi-center data set of over 4,000 patients now looking at basically nerve root level problems, SSTPs, EMGs, as well as motor evoked potentials. And the take-home message here is a subset of patients who had a drop in motor evoked potential that did not recover by the end of the surgery that was highly predictive of a postoperative motor deficit. The ones who recovered to better than 50% of a drop before closure were less likely to have a motor deficit postoperatively. And again, the transcranial MEPs being important there. Let's do a couple more scenarios. So direct lateral surgery in a lumbar spine. This has certainly gotten a lot more popular in the last 15 to 20 years, 15 years, I'd say. Who's monitoring their direct laterals, be it an anisoas approach or a transpsoas approach? Who's using nerve monitoring? So I'm a little surprised other people aren't answering her. So, all right, maybe it is most. The first time seemed like fewer, but maybe it is most people. So interesting here, this paper by Mike Riley looked at almost 500 transpsoas surgeries. And in this case, they compared 3 different strategies. So triggered EMGs versus a neurophysiologist doing triggered EMGs versus actually supplementing this with MEPs. What was alarming here is 30% of these cases had some postoperative deficit. 11% motor, more than twice as many were sensory, but some postoperative deficit after pretty simple lumbar degenerative pathology. And what they showed is, although it wasn't perfect, looking at MEPs actually reduced the incidence of femoral nerve palsies or of motor deficits after surgery. Now, what's important here is that the sensitivity was quite a bit less for MEPs in transpsoas, in this case, transpsoas surgery. And one of the things that we might think about, and this was important for me to learn, is normally our SSEPs are done looking at the tibial nerve. But the tibial nerve isn't going to be very sensitive in our upper lumbar or mid lumbar, so our femoral nerve palsies, which is what was seen in the MEPs. So we really ought to be looking at SSEPs to the saphenous nerve. And a study of looking at SSEPs and the saphenous nerve suggested that this was actually highly sensitive and even more sensitive than the MEPs in transpsoas surgeries. So I'm not going to spend a lot of time on this, but just understanding the neuroanatomy of the spinal cord certainly is important in recognizing that our antegrade motor evoked potentials and our retrograde somatosensory evoked potentials are our basic modalities. But other modalities I think we ought to certainly all be recognizing triggered EMGs, can be spontaneous EMGs, a lot less sensitive, but certainly can be useful when we're working right around a lumbar plexus, for example. And also looking specifically at direct stimulation of the spinal cord. And that's something we've done quite a bit with in terms of trying to map the spinal cord. Just a little summary of the strengths and weaknesses in general. The transcranial MEPs are the standard modality that are going to be most sensitive and specific for spinal cord type injury. And I think that the descending neuroevoke potentials, the DNAPs, are something that everybody who's doing deformity ought to be thinking about. And I'll show you another case. And Lionel, I think you had a case recently where we mapped the cord to actually identify exactly where there was a deficit. A little bit about the history is that before we had electrical nerve monitoring, the wake-up test described by Valzel and Stagnara was really what was done routinely. But knowing that this is still something that can be very useful intraoperatively, so if there is a change that's not recoverable, a wake-up is pretty much what we would do standardly. Hoppenfeld described a test, and oftentimes you'll see some of the older surgeons, including me, as an adolescent waking up after deformity surgery, actually doing a clonus test. And there's a phase during the wake up where it's normal type clonus, and if there's not clonus, that could be concerning for somebody having a spinal cord injury after adolescent surgery. And we don't have great sensitivity or specificity on that, but it's pretty sensitive. Just a little more history about the fact that the evolution began with SSEPs, moving through transcranial and motor evoke potentials, and now multiple myotomes are pretty much what we're using for the most sensitivity in the OR. And what we recognize, and Daniel Schwartz is at Penn, has done a lot of work with this, is very good sensitivity with motor evoke potential drops. And in a series of over 1,000 patients, it was quite remarkable how few of these were adolescent idiopathic scoliosis cases. Only about 3% had a real alert intraoperatively. And what they showed is that they were actually able to avoid a permanent loss by responding to an early alert. So 9 of the patients actually did awake with some deficit. They all resolved within 90 days. And the thought is that they might have been much more severe deficits had there not been a response intraoperatively. Having said that, it's still certainly not perfect. And this paper out of the Journal of Neurosurgery suggests that the transcranial motor evoke potential still have a sensitivity and specificity in the mid-90s. So there are definitely still cases that are missed. And that was a systematic review of the literature. So I want to show you a couple more important points here. This is a paper we wrote some time ago now looking at our 3-column osteotomies. And specifically, it was a relatively small number. There's 35 patients who had 3-column osteotomies. But here's what was remarkable, is using multiple myotomes, 70% of these cases had some alert, meaning there was a drop in MEPs, around 50%, that was enough to talk about with nerve monitoring. Now, most of these, 15 out of 25, had a recovery right away, just with some volume resuscitation, increasing the blood pressure. But 10 of them had some persistence of a decline, and they all woke up with at least 1 grade of weakness. Now, this was on a really detailed exam postoperatively, but that ended up being, 29% of the patients had a grade of weakness after a 3-column osteotomy. Now, 9 out of 10 recovered by the time of discharge, so it wasn't even something that was maybe even significant. 1 of them still had weakness at 6 weeks and recovered by 3 months. So in general, these patients recovered really well. But this was really important because that suggested a much higher rate of neural injury than we had thought. And the take-home message here was that the transcranial MEPs were much more sensitive than the SSEPs. In fact, there were very few cases where the SSEPs or EMGs showed any change at all. That was about 10 years before our scoliorist study. And Steve and I and Larry in the AO Spinal Deformity group looked at 3-column osteotomies. And again, rate of neural injury, 23%. So, these are things where you actually look at the outcome. There's a lot of variation in how this is reported, but it's not uncommon after 3-column osteotomies to have neural deficits. And in this case, again, most of them were transient. This is from the ISSG. Again, 28% of patients after complex spine surgery having some measurable neural deficit. And again, Steve, I think this was you again, looking at how do you respond to 3-column osteotomy changes is a big part of this, is recognizing that during a correction, there may be compression. Let me show you at least one more scenario here. This is a 4-year-old boy with a congenital kyphosis. Comes in with a conus pathology, And during the decompression, we have a 50% drop in the MEPs to the lower extremities. And this is an example where the actual approach to this, rather than stopping the surgery and leaving them in kyphosis, was to continue to complete the shortening of the spine, get the correction. And this is something that really Leatherman popularized, this notion of the safety of spinal column shortening in patients with a significant high deformity angular ratio. So although in some of the adolescents, we might consider stopping, reversing a correction, when we're actually doing a VCR, I think about continuing the surgery and getting the spinal column perfusion improved, spinal cord perfusion improved with shortening. One final example for the cervical spine. So this is a woman 72 years old who developed symptoms of cervical myelopathy 12 years after her deformity surgery. And you see multiple levels of stenosis. And in this instance, there were no nerve monitoring changes intraoperatively, but on postoperative day 2, she developed a right-sided deltoid and biceps weakness with no nerve monitoring changes. She recovered within 3 months of the surgery, which is what we might expect from a delayed C5 palsy. But what's interesting here is what about nerve monitoring just briefly in the cervical spine? And I will say that at this point, probably in 2025, I might have treated her with a laminoplasty, but not a lot of evidence that that might have been protective for C5 palsy. And what we recognize is that C5 palsy oftentimes goes undetected. So the role of nerve monitoring in the cervical spine is not nearly as clear. And Dan Resnick wrote about this in a journal of neurosurgery, saying again, there's reliance on electrophysiology really isn't terribly reliable. And this is why there's not a clear consensus for some of the cervical degenerative pathology. I was going to start this with who for cervical myelopathy is using motor evoked potentials. Pretty clear consensus there, but it's not something that's actually a position statement. So this is just a final paper I'll reference is the best practices in intraoperative nerve monitoring. Mike Vitale, Steve Lewis, Larry Lanke were all part of this paper. And the clear best practices is to use nerve monitoring for deformity surgery. And this gives us the opportunity to be sensitive to changes intraoperatively and to actually do things to try and recover motor evoked potentials. And when we recover motor evoked potentials more than 50%, the risk of a postoperative deficit is significantly less. We still need more work with standardized protocols. So thanks for the opportunity to contribute.
We have time for one quick question during the transition.
It was a great summary, and I think, thanks a lot, Sig. I think we just had a great case last week. I had the ISSG visiting fellow, and we lost our signals, and we mapped it out just like Lionel did. We identified it to the T6-7 level, and it turns out during our rod correction, 7 screw windshield wipered into the medial cord on the concave side. Yeah. So we opened up, took the screw out, and the signal came back. It's really nice. And I think direct nerve stimulation, direct cord stimulation when you have changes really helps to localize where the problem is. And it's one of the next steps, I think, for us to become better in monitoring. And I think you highlighted some of the difficulties to try to define the difference between a mechanical problem and a problem, which is very important. And having protocols, because a lot of the research is lumping all types of changes together and understanding the limitations of the monitoring signals that you've mentioned.
And as you pointed out, it's a very different pattern of nerve monitoring loss when you've got a pedicle screw that gets plowed into the cord, where it might almost be more like a Brown-Séquard, as opposed to an ischemic change, which might be MEPs more than SSEPs. So recognizing those patterns, and then when MEPs and SSEPs are out, that's a much more significant problem. So recognizing the pattern, I think, probably gave you a little bit of direction as well. But yeah, the DNAP protocol, it's worth making sure your neurophysiologists know how to do it, because it's really dependent on the sequence of stimulation. It's the direct spinal cord stimulator really requires a sequence of volleys of evoked potentials that allow you to really map the cord well. So it can be really useful in that instance. Thanks.
Thanks, Sig.